Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to look at the updated resuscitation guidance around newborn life support, which was released towards the end of 2025. So we will look at the whole algorithm, but focusing on those changes. And I am eternally grateful for my QEH colleagues who helped me make this video.
My name's Lindsay. I'm one of the ANMPs working on the neonatal unit. Today I'm going to go through the resuscitator with you. We mainly use the Draeger resuscitators here in the Trust, but there is a different style of resuscitator in A&E. We also have the Life Start resuscitator. So the most important thing is that you go away and familiarise yourselves with the equipment in the area in which you're mainly working. When approaching the resuscitator, we can see that we've got a flat platform on which to pop the baby. When it's born, it's accessible from three sides, and the clear sides lift and drop down so you can get closer to the baby. It's height adjustable, so at the bottom on either side are pedals, which mean you can resuscitate, go higher and lower. You should have a stethoscope ready to go there on the side, and round the back we've got power button. Just on the back here. There's also another power button just on the front, so both of those need to be on for everything to be working. Okay, so there are tubes to plug into the wall for the gases for everything to work. So you've got an air and an oxygen tube. If the resuscitator isn't plugged into the wall, it can use cylinder gas, so both the cylinders are here. We just need to make sure they're turned on before we use the gases on the front for any inflation breaths or anything on the baby. Okay, so we're going to start at the top of the functions of the resuscitator and work our way down. So initially we need to make sure the power is on. So we'll do some self-checks when it first turns on. Okay, so just going through sort of the buttons at the top and working our way down. So at the top left here we've got the clock, so this is the timer button, so we would start the clock when the baby is born. Okay, and then we can stop it when we need to. There's also a reset button if, for example, we press it accidentally or we need to restart the clock for any reason. This clock will sound a small alarm at 1 minute, 5 minutes and 10 minutes to remind us to check our APGARs for the baby. This is quite a good feature for delayed cord clamping as well, because it will remind us when the 1 minute mark is. Moving down, we've got the sort of thermal control section. So there's three different heat mechanisms. The first one is the pre-warm. So the pre-warm, when it's turned on, will heat the surface on full 100% heat to power for a little while, and then it will drop down slightly for a little while. And we use this when we're sort of anticipating the arrival of the baby. The next one down, which we use with the sort of arrow keys there, is the manual button. So this is where we can adjust the temperature ourselves. So once we put it into manual mode, we can adjust our heat to power however we like. And this is good for when the baby's about to come out, so we can turn our heater right up if the pre-warm has dropped down at that point. When the heater power is over about 40%, it will sound a regular alarm to remind us to check the baby. So it will say check patient, and we can cancel that alarm by pressing the alarm cancel button. The third mode is baby mode. We don't tend to use this too much sort of at delivery for baby. This relies on a temperature probe which plugs into here, and we can place it on the baby and operate sort of a servo control feature where we set the baby's temperature and the heater adjust itself, but generally we'll be using the manual mode for when the baby's born. Moving down, we have a light, so we can turn the light on and off. This is a keypad lock button, so if we turn this on, it will stop us being able to adjust any of the soft keys on the screen there. Okay, so moving down, we're onto the blender. So this is where we can deliver oxygen to the baby. So the blender's set at 21%, which is our normal initial starting oxygen concentration for resuscitating a term baby, and then we can tweak it up to whichever number we fancy. So obviously for preterms we'd be looking at sort of around about 30% for starting resuscitation there. Moving down, we've got the suction controls. So the suction will only work if the gas supply at the bottom here is on. So we need to turn that one on first before the suction will work. So we turn that on. The suction tubing will come up here, and we can occlude our suction catheter and just check our suction pressures, aiming for about 8 to 10 kilopascals on there for the suction. Just moving around here to show you at the bottom on the left, this is where the suction containers sit down here. So if there's any loose connections, it may be that they're down here. So moving further down, we've got the auto breath section. We don't tend to use this as part of our NLS algorithm here at the Trust, so we won't talk about that today. And then moving down to the last bit, so this is where we would be delivering our inflation and ventilation breaths to baby. So we need to make sure we've got a gas supply first. For the T-piece on the resuscitator to work, we need to have a pressurised gas supply. So we need to either be plugged into the wall with our gas tubing, or we need to have the cylinders on. These cylinders have already been turned on, so you can see that we've got an air supply and we've got an oxygen supply in our cylinders. So we'll turn it on. Normally we'll aim for around about 8 litres for a flow rate. It should be fine for us to be able to sort our pressures out on here. And we want to check that we've got the correct PIP, so the peak inspiratory pressure, and also the correct PEEP for the baby, so that's the peak end expiratory pressure. So for a term baby, we want a PIP of around about 30 and a PEEP of around 6. So our T-piece is plugged in to the patient outlet. We can occlude the end. This will give us our PEEP, so you can see on the patient airway pressure dial we've got a PEEP of around about 6, and then we will occlude our sort of end part of the T-piece to give us the PIP of 30. So we can see our pressures are set there. We can adjust our PIP, our peak inspiratory pressure, by turning this dial here. So I'll just give you an example. If we wanted a preterm baby, we could tweak it down to 25. Okay, and we can adjust our PEEP by turning the dial on the top of the T-piece. So it's got a plus and minus button on the top, so if we want to turn our PEEP up, we can tweak it, and if we want to turn it down, we can twistle it the other way. Okay, so when the resuscitator is set up ready for use, we add a few little bits of kit just to make sure the process is more streamlined should a baby need any support at birth. So we've got a SATS monitor ready to go, and we've got a SATS probe here ready to go as well should the baby require it. We have hats, and we've got 2 sizes of mask generally. So we've got a sort of slightly bigger one. This is more for sort of the term babies, and a smaller one for the smaller preterm babies. In the drawers underneath, we've got normally a supply of hats, some cord clamps, and we do normally have 1 eye gel in there and a laryngoscope should we need to use an eye gel. There's also a bag valve mask, and this is good for if the gas supply fails in any way and we need to revert back to using a bag valve mask, because these can be used without the pressurised gases. We've also got plastic bags, so these are for preterm babies under 32 weeks, and there's some spare tubing and suction catheters in there as well. So we're now going to talk about the adaptations that we would make for a preterm baby. So for the purposes of newborn life support, we'd be referring to as a preterm baby as any baby under 32 weeks. These are the babies where we would make small changes. So the first thing we're going to talk about is delayed cord clamping. So this is something that we try and offer for all babies because of the known benefits. For preterm babies, those benefits are even more important. So delayed cord clamping in a preterm baby can improve survival, it can improve their haemoglobin and their hematocrit in the early days of life, and it can reduce the need for blood transfusion for these babies. We aim for delayed cord clamping of at least 60 seconds, ideally slightly longer if we can. This, for a preterm baby, requires a little bit more communication and good teamwork because these babies are more at risk of becoming cold or potentially needing some extra stabilisation with breathing support. So it's really important before a preterm baby's delivery that we have these discussions amongst the teams to work out how we're going to facilitate delayed cord clamping if the baby is able to. If the baby needs resuscitation, we wouldn't delay the resuscitation to provide delayed cord clamping. The priority will always be the resuscitation of the baby. The NLS, or the Resus Council, do state that cord milking could be considered for these babies, potentially, but definitely not for babies under 28 weeks because it increases the risk of intraventricular hemorrhage. So once we're hopefully doing our delayed cord clamping for the preterm baby, we would be assessing the baby's condition and starting to implement some of those thermal control measures to help keep this baby warm. Obviously we know that babies born at 32 weeks are a lot smaller, they're more lacking in subcutaneous fat, their tone isn't quite as good for helping to keep their temperature, and they've got very thin skin as well, so they lose a lot of heat through evaporation. So with these babies we'll be making sure their head is reasonably dry, popping a hat on and popping them the rest of their body undried into a plastic bag. So we have the plastic bags, there's some under the resuscitaire, you can open them up and they've got sort of a velcro closure strip down the middle for placing the baby in. So we need to make sure that once they're in the plastic bag that they also have a radiant heat source. So the baby will need to go either sort of under the resuscitaire, so you've got the heater over the top here, or onto a thermal mattress, or sometimes both if these babies are particularly cold. So in babies under 32 weeks, their lungs are a little bit more fragile than a term baby. They've also got quite a compliant chest wall, so it moves very easily. So these babies' lungs are more at risk of over-distension if we deliver high pressures. This can cause sort of a cascade of inflammation and can predispose them to chronic lung disease, which we obviously want to avoid for these babies. So we would aim to deliver lower pressures for these babies than a full-term one. We'd be looking at a PIP, so a peak inspiratory pressure of 25, and a PEEP of 6 for these babies. A lot of preterm babies come out and don't actually need full resuscitation. They might just need some gentle transitioning, some gentle stabilisation. It might be that they just need the PEEP aspect. So if they've actually there is some respiratory effort there, some regular respiratory effort, we can supply PEEP with the T-piece just by creating a good seal with the mask and not actually using our finger to occlude the hole at the top, which would deliver the breaths. So the final thing we need to think about for these babies under 32 weeks is the use of oxygen. So the Resus Council recommends that we start resuscitation for babies under 32 weeks using 30% oxygen, which is different to a term baby where they recommend the use of 21%, so air. We're going to start the resuscitation in 30%, but it's very important that we get a SATS probe on this baby quite quickly. We wouldn't delay our resuscitation to put the SATS probe on, but if we've got a second pair of hands there, they could be getting the SATS probe on relatively early. So the SATS probes are stocked on the resuscitaire, as we've said. It goes on the right wrist, which will give us a pre-ductal saturation reading. So this is the blood that would perfuse the brain. And the SATS limits have actually changed slightly this year, so they will be on some new laminated cards that will be on the resuscitaires, but they have changed, so just have a look at those. So once the SATS probe is in position, it will take a little while to pick up a trace, but once we've got a good trace on our SATS monitor, we'll be able to get a reading of the baby's saturations. So it's really important in babies that are preterm that we try and avoid giving them too much or too little oxygen. So it's important that we titrate our oxygen very early to make sure the saturations are within the recommended ranges. So just to summarise, the 5 things that we would be remembering for a preterm baby would be providing delayed cord clamping if it's safe to do so, keeping the baby warm, providing gentle lung inflation and getting that SATS probe on early so we can try titrate our oxygen to avoid giving too much or too little oxygen. We've prepared the room for delivery. We're on delivery suite, so we've brought our resuscitator in, it's plugged in and turned on. And as baby is born, we're going to start our clock, and then we are going to dry baby whilst we're skin to skin and assessing baby. We're going to be assessing baby's tone. Congratulations, Holly.
Thank you.
Making sure baby is adequately dried. Get rid of our wet towel and replace with a dry towel so that we are keeping baby warm, because that's our first step of our resuscitation. Popping a hat on and assessing, and we're assessing our tone, and we're assessing whether the baby is breathing. This baby has got some irregular breathing only, and we're going to assess our heart rate. If the heart rate is okay, we're going to leave the cord intact. However, this baby's heart rate is slow. It's below 60, so as we can't initiate resuscitation with next to mum, we're going to need to clamp and cut this cord and then commence our resuscitation on the resuscitation. Okay, so baby has now come onto the resuscitator, so I'm going to dry my baby and stimulate and get rid of this towel again. Even though we've had a fresh towel, it's worth changing it again and making sure that our baby is warm. I'm going to wrap baby, leaving the chest exposed, and I'm going to pop the head into a neutral position. Remember, babies have got quite a large occiput, and if they are floppy, they are likely to close their own airway. So in a neutral position, that nice horizontal position to assess baby. So I can assess my tone. This baby is still floppy. My heart rate remains slow, and I've got irregular breathing. So this baby needs some help. So I'm going to call for help, and I'm going to ask somebody to put out a 2222 neonatal emergency for me, but I'm going to continue and do. So the first thing that I need this baby to have is some inflation breaths, and those are those long breaths that push all of the fluid out of the lungs and make space for the air. I'm going to be using my gases at 30 and 6 pressures, so the 30 for when I'm pushing the air into this baby to push out that fluid from baby's lungs, and the 6 is the PEEP, and that just keeps a gentle airflow through to stop the baby's lungs closing back down again, and it makes it easier for baby to breathe. I'm going to be measuring for the correct size face mask, so I put the edge of my face mask into the cleft of the lip and over and onto the nose, and I want it to be covering baby's nose and mouth nicely. That is too small, so we shall try the next size. And you can see there that I popped it into that cleft of the chin, rolled over onto the face, and I'm not overhanging the chin, and I'm not into the eyes either. And I'm going to then attach it to my gas source, whether it's a bag valve mask or the cylinders, and I'm going to then roll it back on. By rolling it on, you get a much better seal, and I'm going to be using a C and an E grip. So C onto the top of the mask so that I can press down on the hard bit of the mask, and then a capital E with my other 3 fingers under that jaw and lifting that chin up. So by putting some pressure down on the mask and pulling up the chin, I get a really nice seal. And I'm going to do 5 inflation breaths, lasting 2 to 3 seconds at a pressure of 30/6, because this is a term baby. So I'm going to include this for 3 seconds, and I'm going to count 1, 2, 3, off, 2, 2, 3, off, 3, 3, 3, off, 4 inflation breaths, off, 5 inflation breaths, off. And whilst I'm doing that, I'm observing to see if we've got chest wall rise. If I have got chest wall rise, I know that I've got air into those lungs, and that's what we want to be confirming. So after I've done my 5 inflation breaths, I'm going to reassess my baby. And it's the same again. I'm assessing, have I got good tone? I haven't. I've still got poor tone. Making sure that I keep this head in the neutral position. Checking my heart rate. It is still slow.
and my baby isn't breathing. But importantly, a check-in, did I get chest wall rise when I was doing those inflation breaths? And I did see the chest wall rise on the last few of the inflation breaths, so I know that I have inflated those lungs, I've pushed out that fluid, so I can move on to the next step of the algorithm, which is this baby's not breathing, so he needs to have some ventilation breaths. So same positioning with our face mask, but instead of doing those long inflation breaths, I'm going to do mimicking the baby's normal breathing. So I'm doing ventilation breaths. It's a rate of 30 in a minute, which what that means is that you're on for 1 second, 1, and off for a second, 2, off. So if you don't have a resuscitator, or the gases are broken, or you're out in community or down a corridor, you might not be able to use a T-piece, it might not be available. So your alternative is a bag valve mask, and all the resuscitators have them underneath. Before you use a bag valve mask, it's important to make sure that the blow-off valve is working. We don't want to hear that noise when we're using it, but it's important to make sure that it blows off to keep the pressures correct for the baby. So same method, attach in your face mask, and I'm going to show you how to do inflation breath. So still rolling on our face mask with our C and our E grip, and I'm just going to squeeze this bag really gently for the 2 to 3 seconds. So 1, 2, 3, off, 2, 2, 3, off, 3, 2, 3, off, 4, 2, 3, off, 5, 2, 3, off. What you'll see that I was doing there was that really slow squeeze. If you just do a rapid squeeze and hold it closed for 3 seconds, you're not actually blowing the air in, it's only blowing the air in as you are squeezing. So it's really important to keep that as a nice gentle squeeze that is moving gradually your fingers closer together. Okay, and if I'm going to then move on and do my ventilation breaths after I've assessed my baby, I'm going to roll my mask back on, and I'm just going to very gently squeeze just enough to move that chest. So 1 and 2 and 3, and again we're doing the 15 breaths over 30 seconds. Okay, so we've shown you how to do inflation breaths and ventilation breaths with both the T-piece and the bag valve mask, and on both occasions we have had chest wall rise, so we've been able to move on in the algorithm. However, it doesn't always work like that. Sometimes you don't get that chest wall rise. So we're now going to look at some of the other techniques that we can use to ensure that that chest is rising and we have had air entry before we move on in our algorithm. So the first one that we're going to look at is a jaw thrust. So as you know, these babies are probably floppy, they've got that large occiput, and a common reason for not getting air in is that they've got an obstruction of their tongue. So we need to lift that tongue out of the way, which by doing a jaw thrust and bringing that chin upwards towards the ceiling, we're going to move that jaw. So I'm going to secure baby's head, just cradle around so I've got it nice and secure, and I'm going to put my thumbs onto the orbital ridges, those cheekbones, and then I'm going to run my fingers down, doesn't matter which finger you use, down the jawline, and I'm going to reach the angle of the jaw. It's quite close to under the ears, and what I'm going to do is lift up. I need to put a little bit of counter pressure on with my thumbs, and I'm going to lift up that jaw. And then once I've done that, I can only do this with an assistant. My assistant is going to roll on the face mask for me. Lovely, thank you, Holly. And then we're going to do inflation breaths. So 1, 2, 3, off, 2, 12, put back on, 2, 2, 3, off, 3, 2, 3, off, 4, 2, 3, off, 5, 2, 3, off. And you can see we need to have really nice coordination between the two of us. So we've shown you a jaw thrust, but maybe that doesn't work, or maybe you haven't got a second person to assist with it. Maybe if you've got at home, you might want to go to other manoeuvres first. And what we can next have a look at is using our eye gel. So the eye gels come in their sterile packet, which you need to open up and take out. and we use a size 1 eye gel, which is for all babies between about 2 kilos and 5 kilos, but obviously we're not going to weigh. They come in this little kind of pink cage, and you do need to put some lubrication on. So we would use the Optilube and pop some on this bit here and wipe the eye gel on it, being careful not to block the airway. I'm going to have everything ready before I start. So I've got my eye gel, I've got my laryngoscope. I'm going to check that my light is working. A laryngoscope is a left-handed instrument. It starts with L, so I'm going to hold it in my left hand and I'm going to make it into an L shape. It's not very intuitive, so do have a go. You need to hold it in your left hand, whether you're right-handed or left-handed, because of where the light and the groove is. I'm also going to be looking at this point and seeing if I need to suction anything out. We don't suction before this point. We have a go at putting in inflation breaths, but if I'm going to have a look, I'm going to see if there's any big globs of meconium or blood or vernix or anything, and then suction them out, which might be our problem. Okay, so I've got all of my equipment ready. So I've got my laryngoscope in my left hand, and I'm going to protect my baby's upper lip, slide the blade down over the baby's tongue so that I can see to the back of the mouth. If I do see a significant lump of meconium or blood, I will suction. If I don't, I'm not going to go anywhere near this baby with the suction. If I do suction out, then what I can then do is take out my laryngoscope and put my face mask back on. If I don't suction out, then I'm going to need to put my eye gel in. So holding my baby's tongue out of the way, I'm going to slide the eye gel in the direction of travel. I can see the numbers on the top. Slide it into the back, and it's going to cover at the back of the throat and make a seal. And as it hits the baby's warmth, the end of the eye gel swells up and makes a seal. I'm going to attach my T-piece or my bag valve mask, and I'm just going to hold it securely. And because I haven't seen any chest wall rise, I'm going to do my inflation breaths. If I'm putting in the eye gel later, when I'm starting maybe cardiac compressions, then I might be continuing with ventilation breaths, but just make sure that you know where you are in the algorithm. And I'm just going to do it in the same way. So 1, 2, 3, off, and I'm going to do 5 of those. So we've shown you how to do inflation breaths and ventilation breaths. So we're now going to move on to do the assessment following our first round of ventilation breaths. And as my helper has now arrived, please could you put a SATS probe on. We're going to put it onto the right wrist or the right hand. It takes a little while for a reading to get through, but it is helpful information for the ongoing resuscitation. So as Lindsay's putting the SATS probe on, I'm going to assess my baby. We want to continue doing things all the way through. So our baby's tone is still floppy. Our heart rate remains low, so it's below 60. My baby isn't breathing, but during our ventilation breaths, we did get that chest wall rise. So because our heart rate is below 60, we don't need to count it for very long. That's my indication to do cardiac compressions. So baby's heart rate is below 60 or thereabouts, so that's our indication for starting cardiac compressions. Now, if we can and we have access to it, this is the point that we put 100% oxygen on for all babies at starting cardiac compressions. So we turn the blender on the resuscitator to 100. If you're at home or using a bag valve mask, we'll attach the oxygen directly to the bag valve mask. So the aim of the cardiac compressions is to move the blood between the heart to the lungs and back again, to get that oxygenated blood to the heart tissues so that they can start to pump correctly. So it's important to squeeze adequately, but also to allow a recoil for that blood to come back from the lungs into the heart tissues. So ideally we are going to use an encircling technique. So our landmark is the nipple line or the armpit line, and at just about a centimetre below, with 2 thumbs on top of each other, with my hands around the sides of the baby. And I'm going to squeeze this baby's chest about 1/3 or 1/2 of the depth, making sure that each time I come off completely. We're going to do it at a rate of 3 to 1, so 1 ventilation breath followed by 3 chest compressions, and we're aiming for a rate of 120 events in a minute. So what that means is 1 ventilation breaths, 3 cardiac compressions should take about 2 seconds each, and we're going to do it for 30 seconds, which is roughly 15 ventilation breaths. So Lindsay, if you can do the first breath, and if you can count it out loud, that would help, please.
Okay. 1,
1, 2, 3.
2,
1, 2, 3.
3,
1, 2, 3.
4,
1, 2, 3.
5,
1, 2, 3.
6,
1, 2, 3.
7,
1, 2, 3.
8,
1, 2, 3.
9,
1, 2, 3.
10,
1, 2, 3.
11,
1, 2, 3.
12,
1, 2, 3.
13,
1, 2, 3.
14,
1, 2, 3.
15.
1, 2, 3. So following our first round of cardiac compressions, we're going to reassess our baby. So our tone is probably still floppy, and is our baby breathing? We're not breathing adequately. And what's my heart rate? If our heart rate has come up and is above 60, then we don't need to continue with our cardiac compressions, but this baby isn't breathing effectively, so we need to continue with our ventilation, with reviewing every 30 seconds and things. If we assess our baby and our heart rate remains below 60, we need to continue with our rounds of cardiac compressions, and this is when the team would be starting to think about medications to help stimulate this heart. So that is usually using a umbilical catheter. Sometimes it might be the intraosseal technique as well, but whilst somebody's trying to put in a UVC, you're going to be in the way if you're doing the encircling technique. So you might want to consider the 2-finger technique. So it's the same landmarks, same positioning, trying to keep your fingers nice and vertical. You're still going to be compressing to 1/3 to 1/2 of the baby's chest at the ratio of 3 to 1. So Lindsay, if you can go please.
1,
1, 2, 3.
2,
2, 3.
3.
And you keep that going whilst they're putting in the catheter. Once the catheter is in, you can then change back to being encircling. So once the UVC is in, the medications that are commonly used are adrenaline, and that's given at 4-minute intervals, followed by a flush, continuing your cardiac compressions throughout, and then a reassessment. Babies will occasionally need some volume, which is either O negative or saline. And that is given to replace any volume that is lost, and occasionally babies might have some glucose, which is generally used following a blood sugar reading. So in summary, if we need to do newborn life support and resuscitation of a newborn, we're going to follow our algorithm, and that applies to whichever area you are in, whether it's a 2-day, 5-day-old collapsed baby on NICU or at home, or whether it's a brand newborn baby at the point of birth. And we're going to make sure that we're always drying our baby, getting rid of the wet towels and keeping our baby nice and warm. And we're going to put baby's head into a neutral position whilst we do our assessment. And the things that we're assessing is the baby's tone, the heart rate and the breathing. And if this baby needs help, we're going to be calling for help using our emergency buzzer, 2222 neonatal emergency, or 999 if you're out of the hospital. And we're going to be moving on and doing our inflation breaths. And those are those breaths that last 2 to 3 seconds, nice and long, pushing out the fluid from baby's nose. And you're going to do 5 of them at a pressure of 30/6 for a term baby, or 25/6 for those preterm little babies. After you've done your round of 5 inflation breaths, you're going to assess your baby in the tone, the heart rate, the breathing, and really significantly, did you see that chest wall rise? Did you actually inflate those lungs? And if you haven't inflated them, you can't move on to the next step of the algorithm. If you have inflated them, you can move on. If you haven't inflated them, that's when you might want to look at the other techniques that we've talked about, the jaw thrust, the having a look and do some suction if there's meconium or something, or putting in an eye gel. You could also, if there's somebody capable of putting in an ET tube, that's an option, and occasionally maybe increasing the pressures slightly will help those lungs to inflate. Once you've inflated those lungs, you can move on to the next step of the ventilation breaths. Those shorter breaths lasting 1 second, that's a rate of 30 in a minute, and you're going to do them for 30 seconds, which is 15 ventilation breaths. And then you're going to reassess the tone, the heart rate, the breathing, and was that chest still moving?
and depending on your findings will depend on what you do next. If baby's heart rate is below 60, you're going to introduce your cardiac compressions, usually using an encircling technique, but you might want to use the 2-finger technique if you're doing it solo, or if the venous access is going in so you're out of the way. But ideally the encircling technique, 3 cardiac compressions to 1 ventilation breath, do around for 30 seconds, reassess your baby. If on your reassessment baby's heart rate remains low, that's when we would then start to think about the medications and putting in that venous catheter and things like that. If baby's heart rate has become above 60, cardiac compressions can be stopped, but if baby's not breathing regularly, then continue with your ventilation breath. But overall, please make sure that at every point you make sure that you've confirmed that you have done that step before moving on to the next step and doing that holistic assessment.
And there you have it, the updated guidance. I hope that's helped update your knowledge around newborn life support. If you're interested in doing the newborn life support course, it's generally a 1-day course. You can access the venues that it takes place on the UK Resuscitation Council website, which I will put the address and the link down in the description box. I look forward to seeing you next time.